Hello, everyone. My name is Sharice Magoon, and I would like to welcome you to a harm reduction approach to overdose prevention. We are providing this training in recognition of International Overdose Awareness Day. And before we get started, I would like to share with you a welcome message from President Henrich. So give me a moment while I pull it up.
Hi, everybody. My name is Bill Henrich, and I serve as president of UT Health San Antonio. I am a nephrologist. I'm pleased to provide these brief remarks to precede this training program on a very important day, International Overdose Awareness Day. I am grateful to esteemed members of the faculty for today, from UT Health San Antonio, Lisa Cleveland, from UT Austin College of Pharmacy, Lucas Hill, and from the Dell Medical School at UT Austin, Claire Zagorski. I'm grateful to them for their leadership of this important initiative. As many of you are no doubt aware, the opioid epidemic in the United States has grown more deadly since the arrival of COVID-19. According to experts, although the number of opioid prescriptions has decreased by 37%, overdoses and deaths are now also fueled by illicitly manufactured fentanyl, methamphetamines, cocaine, and heroin. In many areas of our country, the pandemic is also resulting in an increased number of people in recovery who are relapsing. At the same time, the pandemic is making it harder for clinics to provide patients with the support they need. So 40 states in the United States now report an increase in overdose deaths since the pandemic began, and that includes Texas. Last year, 72,000 American lives were lost due to overdose. Unfortunately, I believe that 2020 will far surpass that number. Now, just a few weeks ago, the American Medical Association released policy recommendations addressing opioid use during COVID-19. One of their recommendations calls for the need for an evidence-based harm reduction approach to overdose prevention, which includes overdose awareness and community access to the life-saving medication naloxone. This training is a timely response to this recommendation. So it's my hope that the training you will receive today will decrease the number of Texans and Americans affected by this terrible affliction of opioid use disorder and save the lives of many of our fellow Texans. My thanks, my personal thanks to each of you for your passion in this area, for your commitment to assist with one of the most devastating public health emergencies for our generation. Thank you very much.
Hello, everyone. My name is Lisa Cleveland, and I'm an associate professor here at UT Health School of Nursing. I want to personally welcome you to this afternoon's training. It's something that I and the other speakers are very passionate about. I also want to introduce you to Ms. Sharice Magoon, who is our continuing education coordinator here with our Department of Lifelong Learning. She is going to be our wingman and our technical expert. Did you want to say hello, Sharice?
Hello, everybody.
I'd also would like to give an opportunity for my colleagues today to introduce themselves, Dr. Lucas Hill and Claire Zagorski. Lucas?
Howdy, I'm Dr. Hill from the UT College of Pharmacy, Director of the Pharmacy Addictions Research and Medicine Program, and we really I very much appreciate the opportunity to contribute today. I know you all know Dr. Cleveland extremely well down there, leading remarkable opioid-related efforts through the Texas Targeted Opioid Response And I'd like to think of myself as the Dr. Cleveland at UT Austin, but I don't know if I quite deserve that level of recognition. But again, very happy to be here. And Claire?
And I'm Claire Zagorski. I'm thrilled to be here. I'm the program coordinator and harm reduction instructor at the Pharmacy Addiction Research and Medicine program, as well at the University of Texas College of Pharmacy. So I'm thrilled that you're all here today.
Thank you, Lucas and Claire. Sharice, next slide. Before we start our presentation today, we want to review some of our funding information. Okay, that's all right. There you go. Funding for this program was made possible in part by grant awards from the Substance Abuse and Mental Health Services Administration. The views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor the Texas Health and Human Services, nor does it mention of trade names, commercial practices, or organizations imply endorsement by the U.S. or Texas government. Next. The presenters have no relevant financial relationships or other potential conflicts of interest to disclose. And with that housekeeping out of the way, one more thing before I turn it over to you, Claire. I wanted to thank all of our registrants today for very generously submitting your scenarios for us to review ahead of time, as well as some questions you have. We've compiled all of those and we'll be addressing those at the end of the presentation. Throughout the presentation, however, if questions arise, please use the chat box. Sharice will help me monitor that, and we can address those questions at the end of the presentation as well. And with that, I'm going to turn it over to Claire.
All right, thank you so much, Dr. Cleveland. All right, next, please. So we're going to talk about a few different things in this module. We're going to talk about what harm reduction is, its historical context, and the historical context of drug use for humans, drug overdose trends here in the US since about the year 1999-2000. Then we're going to dig into recognizing the signs and symptoms of an opioid overdose, how to respond to it, and how you can all take this information and go make your community better and safer. Next, please. Okay, so take a brief moment, have a look at everything that's up on this screen, and try to see if you can figure out a common thread between all of them. So they all address different issues. We've got face masks, very relevant right now, condoms, seat belts, bike helmets, and vaccines. So these all address different things, but they all have one major thread in common. And that is that, and someone got it in the chat. So these are all about prevention and kind of safety in advance of something. Specifically, they're reducing some kind of harm associated with some kind of activity that we accept as being essentially unavoidable. Next, please. So I imagine everyone on this webinar understands the importance of those tools and agrees that they're important. And so if you do, then you already understand the basis and the fundamental idea of harm reduction. So this is already here and it's already with us. So we could technically ban bicycles, driving cars, having sex, but I don't think that any of those are especially realistic or good goals to have. So we use things like bike helmets, seatbelts, and condoms to try to make the activities safer. So that's an important kind of basic fundamental thought to keep in the back of your mind as we move forward. Next. So harm reduction is a pretty broad concept, but it has two really fundamental truisms at its core. One is that illicit drug use is a reality for humans, and it's been so throughout recorded history and into the present day. At the same time, it also acknowledges that there are very real and significant dangers associated with drug use as we know it today. So these things may seem to be opposed to one another, but they're really not. And there's common ground to be found here. And that's where harm reduction thrives. So harm reduction is not one specific set of tools. It's not a specific protocol. It's nothing that rigid. It should be adapted and molded to suit individuals or communities even. So it's important to remember our big maxim in harm reduction, which is meet them where they're at. And if you're a student of public health, or you were at one point, you probably recognize that, because this is also something that public health professionals love to hold up as an important tenet of their field. So it's important to remember that we need to go to the patient, to the individual, to the community, not expect them to meet us at the hospital or the clinic. Next, please. So a little bit of brief context. So as I mentioned earlier, drug use has been a reality for humans since literally we have recorded history. So they've been used in religious and medicinal contexts as well as recreational contexts. And we have a lot of old evidence of this. So it's important to remember that drug use is not a modern phenomenon. I think a lot of us assume that it is because that's just kind of how we think of it. But it's a very old thing. Aristotle wrote about the dangers of alcohol withdrawal on a fetus or a pregnant woman. We've got evidence from Sumerian civilizations that are over 8,000 years old of drug use. And this image over here is a statue of a Minoan goddess from 1500 BC. And the little, those are poppy capsules. They look an awful lot like alien antenna, but they are capsules from the opium poppy. And this has been broadly interpreted by archaeologists to be kind of in honor of the power of opium. Next, please.
All right, so I'm going to take over here and pick up where Claire left off with the historical context. And let's focus a little bit more on contemporary opioid related issues, use and regulation. So if we start with this opium poppy that you see, you may actually have seen these growing in the United States. You can legally grow opium poppies, but what you cannot do is score the outside. It causes a white milky substance to leak out, milk of the poppy if you're a Game of Thrones fan. It dries up and it turns into a brown sticky substance that can be smoked or changed into other formulations called opium. So that was historically how people would become intoxicated on an opioid. They would smoke opium or use it in another form. Around the year 1800, the first ever active drug was isolated from a plant, and that was morphine, depicted by the molecule that's shown in the white square on this slide. And morphine became well known as an incredibly effective pain reliever and anesthetic, thought to be ideal and a wonder drug for battlefield surgeries, and was especially used in military circumstances. What we, well, I wasn't around then, but what was demonstrated or seen over time was a tolerance to the effects of morphine when it was used consistently. So higher doses would be needed to achieve the same level of pain relief. And it would also cause withdrawal if a person who had been using it consistently were to not get a dose or not have a dose for an extended period of time. And that exhibits that withdrawal demonstrates that a person has developed a physical dependence on this exogenous opioid entering their body. So individuals who experienced what was called soldier's disease at the time were exhibiting telltale signs of physical dependence to opioids. And when opioids were withdrawn, the person would experience withdrawal and in some cases would experience craving for the substance. And the diagnostic and statistical manual was not around back then. There was not a diagnostic criteria for substance use disorder. And not all patients who exhibited dependence would qualify for that, but we'll get into that later if we have time. But I will point out that certainly there was recognition that there were problems associated with widespread use of morphine. And a company that we know now as the makers of aspirin, Bayer Pharmaceuticals, found a way to capitalize on that. They figured out that if they changed those hydroxyl groups, those OHs, to acetyl groups, you could see a molecule that would cross the blood-brain barrier much more readily and would exhibit a more potent central effect. So they began in around 1910 sending packets of free heroin to the homes of people in the United States and suggesting that it could be used as a treatment in the same way that morphine was for a variety of ailments, and that it was also a good replacement, a good treatment for morphine addiction or soldier's disease. Certainly today, I think we've got some historical perspective and we can recognize that that didn't work out very well. So from the early 1900s through today, we've seen a change, a general increase in regulations that limit access to pharmaceutical opioids. However, those limitations, those regulatory changes, still led to hydrocodone acetaminophen, or brand name Vicodin, being the most prescribed drug in the United States from 2006 to 2013. So when I started working in a pharmacy, a community pharmacy in 2008, I will tell you, I was shocked. There's a giant shelf of fast movers that is never without it's in arm's reach of the pharmacist because it's the bottles they're opening all day and dispensing. And a giant 500 count bottle of generic Vicodin was always prominently on the fast movers shelf. And before that, I had only ever seen a Vicodin pill on the cover of my Marshall Mathers LP that I got when I was 10 years old and hid from my mom. I thought that this was a truly problematic drug. I did not have any idea how widespread its use was. So now today, certainly we have respect and understanding for some of the challenges and problems associated with widespread use of hydrocodone. And we're going to get into that beginning on the next slide. So this is a depiction not just of opioid-related overdose deaths, but of all drug overdose deaths over time from 1980 through 2018. And you can see a dramatic increase beginning around 1990, but really accelerating after the year 2000. While there was a small blip, a slight decrease from 2017 through 2018, preliminary data already has shown that there was an increase from 2018 to 2019, and we can strongly anticipate that the 2020 numbers are going to be far worse due to the COVID-related problems that you heard about from the president earlier. On the next slide, we can dive a little bit more into the contributions of various opioid forms over time. So from 1999 to 2008, opioid prescribing quadrupled in response to a variety of factors, but probably the most well-known and most substantial being pain as the fifth vital sign, increased assessment and treatment of pain, pressure on providers, especially prescribers in hospital situations, to quickly decrease a pain score. So it had the effect that was intended. Pain scores did seem to improve, at least short term, but we had a massive increase in the number of opioids prescribed and a perfect correlation, a fourfold increase in opioid overdose deaths from 1999 to 2008 as well. So things started to level off a bit. As you can see, deaths due to prescription opioids or opioid analgesics, they slowed down, they plateaued beginning around 2010. And there are a variety of factors that contributed to that. These were mostly what I would refer to as supply reduction strategies. So we've kind of got harm reduction on the one side, which we're going to promote heavily today, and supply reduction on the other. And it's not necessarily true that you can only favor one, but certainly in the early 2000s, 2010 timeframe, supply reduction was heavily favored. So we saw implementation of state-level databases where you can search a patient's name and find every controlled substance that's been dispensed to them. Those proliferated in states from 2000 to 2010 and are implemented in every state today. We saw reduced opioid prescribing beginning in 2010. So despite escalating opioid overdose deaths, it's actually true that high dose prescribing and prescribing of any kind has decreased steadily since 2010. And then finally, there's an invention called INTAC, or a tamper-resistant or abuse deterrent formulation that was implemented in OxyContin in 2010. And 2010 really seems to be an inflection point. So this has been an area of focus, these abuse deterrent opioids. It was actually a faculty member at the UT College of Pharmacy, where I am today, who developed this technology. Prior to 2010, if you crushed up an OxyContin tablet, it would turn into a fine white powder, easily snorted or diluted for injection. After 2010, if you got an OxyContin tablet, it would, when crushed, it would turn into a viscous gel that would be impossible to snort and very difficult, though not impossible, to inject. So that was associated and has in a couple of other studies been associated with a substantial reduction in OxyContin-related overdose deaths. However, if we flip to the next slide, you can see what is so true in drug policy time and time again, that this is a story of unanticipated consequences, and that when supply reduction interventions were implemented in isolation without a substantial increase in harm reduction and in evidence-based treatment access, you saw an increase in heroin overdose deaths that more than made up for any improvement that was seen with prescription opioids. And this ties back into the cycle of tolerance, dependence, withdrawal, and craving that I mentioned previously. When you remove the supply of available prescription opioids for misuse, you don't remove the underlying demand. You don't remove the underlying substance use disorder that is driving the use. And so you push people to a more dangerous, more variable illicit market that is more likely to result in death, even from occasional use. Moving on to the next slide, we can see that as I only referred to 2013 in the previous graph, we have a new problem that began soon after. And that is the rise of fully synthetic, potent, illicitly manufactured opioids, or illicitly manufactured fentanyls, IMF. These are not, by and large, fentanyl patches or ampules of fentanyl that you might find in an operating room that are being diverted. Deaths due to fentanyl in the United States are almost entirely related to illicitly manufactured fentanyls that are in the illegal opioid supply as powdered fentanyl or other potent fentanyl analogs. This picture, while I can't vouch for its accuracy, is from Reddit and claims to show equipotent doses of heroin, fentanyl, and carfentanil. Regardless of whether it's perfectly accurate, I can certainly say that it is true that we need to be concerned about highly potent fentanyls, which can be 50, 100, or even more times more potent than heroin or morphine. Moving on to the next slide, this displays how those opioids, those ultra-potent fentanyls, have contributed to deaths over time. So even as far back as 2016, it was true that the plurality of opioid overdose deaths in the United States were related to illicitly manufactured fentanyls, with heroin and prescription opioids accounting for a smaller proportion. Today, fewer than 1/3 of all opioid overdose deaths are related to prescription opioids. And this is CDC data, so I don't want to get too detailed, but I will say that a person who were to die because they were a regular heroin user, the person they were buying from was incarcerated, they purchased a hydrocodone or oxycodone tablet to hold off withdrawal and get through, they bought from a new dealer who gave them something that was mostly fentanyl, and they die from an overdose of fentanyl, they're going to show up on all three of these lines. Now, that's just one case example, but what I mean to convey with that is that even though you can see that blue line depicting prescription opioids does appear to be increasing, it is not. The number of people who are dying purely due to prescription opioids is steady or slightly decreasing if you isolate for situations in which an illicitly manufactured fentanyl was also present. Now, at this point, I'm going to hand it over to Dr. Cleveland, give us a little more perspective on treatment and relapse. Thank you.
Next slide. Thanks, Lucas. So to Lucas's point, I think that, you know, although there have been really horrible consequences that have, you know, come from the current U.S. opioid crisis, I do think we've learned a lot over the past several decades. And one of those lessons, hopefully, is that we are finally beginning to recognize addiction as the disease it is, rather than a moral failing or a moral shortcoming. It truly is a disease of the brain. And not only is it a disease of the brain, but it is a chronic disease. Okay, not unlike other types of chronic diseases. And I really encourage you to think of it that way. So we know as human beings, we do experience chronic diseases, and these might be hypertension, asthma, high high cholesterol. We might even consider obesity to be a chronic disease. And so with that said, the relapse rate for substance use disorder is really on par with other types of chronic diseases, such as hypertension and asthma, about 40 to 60%. And so we really need to be thinking about addiction within that context. So kind of this previous thought that, okay, you went to 30 days rehab, why aren't you cured? That's not the way chronic diseases exist. And so these are diseases that can be managed, however, and that's the good news, particularly when we talk about opioid use disorder. Next slide. So Lucas discussed how when you ingest an opioid, it does have the ability to manage pain, but at high levels, it can also cause a sense of euphoria and well-being. People who use opioids oftentimes refer to this as like a warm hug, and it feels really good. But then what happens, particularly with short-acting opioids, and what I'm trying to convey in this picture, I think of it as sort of like a roller coaster. If you look at the line that's made up of the circles that's going up and down, so most short-acting opioids such as Vicodin or heroin last maybe 4 to 6 hours. And so when first ingested, there's this high, this incredible sense of euphoria that's very quickly then accompanied by withdrawal. And so it creates this cycle of up and down, of high followed by withdrawal and seeking more. And really over time, it becomes an effort just to prevent the withdrawal symptoms. And so when we talk about withdrawal symptoms, we're talking about GI symptoms, so vomiting, diarrhea, shaking, you can have a fever, and just horrible, intense cravings. Rarely is it ever lethal, but individuals who have experienced withdrawal say they feel like they're dying. So it's incredibly unpleasant, and it's really what leads to that drug-seeking behavior over time, to prevent that sense of discomfort and just being really sick. So now if you look at the line that's created with the triangles, that is displaying what we medication-assisted treatment, often now being more commonly referred to as medication-assisted recovery, because it is a form of recovery. And so these are medications such as methadone or a newer drug called buprenorphine. Some of you may know of it as Suboxone. So these are very long-acting opioids. And so when you ingest one of these, if it's dosed appropriately, you shouldn't get that high. But what will happen is it will last longer and will keep the person just in a sense of comfort, where they're not experiencing euphoria, but they're also not experiencing withdrawal. And the reason this is so important is because there's sort of this common misconception and the stigma that surrounds medication-assisted treatment as, oh, you're just replacing one drug with another. That really is not true. These medications work very differently. And once an individual is no longer being faced with seeking more of the drug so they don't experience the withdrawal, they can actually get on to some other types of activities, such as, whether it's counseling or some other forms of recovery treatment. Next slide. So we mentioned that there are many, aspects to how opioids impact the body. We talked about how it can create a sense of euphoria, it can take care of our pain, but at high doses, it also has a side effect, which is that it can depress our respiratory system, our respiratory drive within our brains. And so that's where we really have to be concerned, and that's what is underlying overdose deaths. Next slide. And so overdose can kind of happen in phases. So somebody ingests an opioid, they may become very high or acutely intoxicated, and this would appear as they may have small pupils, their speech may slow, their movement may slow, they may have some scratching of their skin, and they may be mildly responsive. So you call their name and they might respond to you, but they're not very very aware. And so if you've ever seen somebody very intoxicated on alcohol, it may look somewhat similar. Next slide. So acute overdose, which can lead to death, really is characterized by slow or shallow breathing, and we may have very irregular breathing, very constricted small pupils. The person may be completely unresponsive. You call their name. You may even do a sternal rub where you rub your knuckles across their sternum to see if you can awaken them or arouse them, and they don't respond. They may have some bluing of the lips, hands, and feet, and they may have a very deep snoring sound that they're making. And this is really important because this can be misinterpreted as sleeping, but it's not. And it's a very deep, loud snoring, and it can be very irregular as the respiratory center is shutting down in the brain. Next slide.
Okay, I'm going to pick up at this point, and we're going to talk about people who are at risk for an opioid overdose. Next slide, please. So there are several risk factors that have been well defined. All of these are relevant, but let's talk through a couple of them that are especially significant. So right off the bat, has this happened before? Has the patient had a history of an opioid overdose in the past? And coupled with that is a history of illicit or non-medical opioid use. So there's a couple of different ways to approach the use of that, like the language describing that particular thing. Use of methadone or buprenorphine. And as you can see, these things tend to be kind of closely related. Methadone and buprenorphine, as used as a treatment for opioid use disorder, does kind of assume that the patient has had a diagnosis of opioid use disorder at some point. But it's also important, I think, to realize that you don't have to have an opioid use disorder diagnosis in order to be at risk of an opioid overdose. So patients who are on high-dose prescription opioids or long-term prescription opioids are also at risk, as well as the use of extended release opioids. Next slide, please. And then there's a couple of others here, So use of opioids from multiple prescribers or multiple pharmacies. So this is the kind of thing that the prescription monitoring programs that Dr. Hill talked about earlier were trying to get at and identify. And then interacting drugs or medications. So as Dr. Cleveland mentioned just a couple of moments ago, some of the signs and symptoms of both opioid intoxication and opioid overdose have to do with things being slowed down. So it slows down our respiratory drive, it slows down our responsiveness. So as you might guess, taking medications that also behave in a similar manner are especially risky. So a big one that we talk about a lot and that we see a lot is a concurrent use of benzodiazepines. Alcohol is another one that can also kind of couple and make things much more dangerous. Underlying diseases of key organs. So this is not an issue unique to opioids, but it does make this situation especially significant. So the kidneys and the liver especially are very important for metabolizing our drugs and moving them out of our bloodstreams. If a patient has a disease of either one of these organs, then they're going to be less able to move opioids out of their body over time. And if the patient doesn't realize that, it's easy for them to continue taking opioids, but their body hasn't been able to get rid of it as quickly or efficiently as we'd assume. So levels can kind of build up easily. So it's important to be aware of patients who may have underlying organ disease, especially ones that relate to the metabolism of drugs. And then this last one is an especially salient one that we often don't think of, especially in clinical contexts, is recent release from some kind of a controlled context. The big ones being inpatient detox or rehab, jail, and prison. And Dr. Hill mentioned this earlier, but this makes a lot of sense if you just kind of think through it. So if someone, for example, is arrested and goes to jail for 2 weeks, let's say, and that person is used to using, let's say, a gram of heroin every single day, just for simplicity's sake. So during that 2 weeks, if they're unable to access opioids, their tolerance for opioids is going to drop. And this is a pretty fundamental pattern that I imagine most of you understand. And then when they're released, if they decide to then go use heroin again or some other kind of opioid, it's pretty common to want to start back at the dose that you're used to. But the body isn't really ready for that at that point because tolerance has been reduced. So at that point, if this person has a reduced tolerance for opioids, but then uses a gram of heroin just like always, you can see how that would put them at a really big risk for an overdose because they are now consuming an amount that is in excess of their body's ability to tolerate it. Next slide, please. Okay, and then this is a good kind of summation of how we define and categorize these risk factors. When we talk about the illegal use of opioids, so kind of a non-prescribed context, things like increasing dose and then changes in purity of a drug or changes in the drug itself. So earlier we talked about how we've had this progression of the overdose crisis moving from use of prescribed medications to things like heroin, then to things like illicitly manufactured fentanyls. So a big concern now is the contamination of what is believed to be heroin with things like fentanyl. And that is an example of a change in both purity and the drug itself. Then change in route. So we've already talked about a couple of different routes. So far, we've talked about injection drug use, oral drug use, snorting drugs, and there are other ways to explore routes as well. Things like IV drug use is quicker and more dangerous than something like taking a pill orally. Using alone is a major risk factor for overdose. If you overdose on an opioid, you are not going to be able to do anything like call 911 or administer naloxone, which we'll talk about in just a moment. You are not going to be able to help yourself if you are overdosing at that point. So it's important that we encourage people who use drugs to not use alone, to have someone nearby who's aware of them, who knows to call for help and use naloxone. And then long-term use is also coupled in there. The big thing with long-term use has to do with that change of tolerance over time and the need for escalation of dosing in order to achieve the same physiological effect. All right, at this point, I'm going to hand it back off.
Next slide, please, Charisse. So what should you do if you encounter an opioid overdose? Next slide. Really similar to any type of emergency, you're going to want to get help. And so calling 911 is really, really key. If you've taken basic life support, you're going to want to try to arouse the person, and you can do this by calling their name. You can do what's called a sternal rub, which is where you rub down the breastbone with your knuckles, trying to get a response, but you don't want to wait too long with that. Next, if the person is still unresponsive, you can administer nasal naloxone. This is showing a type of nasal naloxone that uses an atomizer on the end, so it can actually be inserted into the nostrils. Dr. Lucas is going to talk about the different forms of naloxone. You may also hear it referred to as Narcan. Narcan is just the trade name for naloxone, so the medications are similar, the same. And so in this particular case, you would assemble the nasal naloxone, spray half up each nostril, and then repeat after 2 to 5 minutes if still not conscious. If you've been trained in rescue breathing, you can perform rescue breathing and CPR. Really, along with naloxone, really what the individual needs is oxygen. And so if you're able to provide rescue breathing for this individual while you're waiting for them to respond, that is a very helpful step in those. And so you want to tilt the head back, open the mouth, and pinch the nose. Start with 2 breaths into the mouth, then 1 breath every 5 seconds, and continue until help arrives. You want to stay with the person, and so there's several reasons why. You want to put this person in the recovery position in case they do awaken. Sometimes they'll be very sick, they may vomit, and so you want to make sure that their airway is safe. The other reason being, depending on what type of opioid and how long that opioid lasts, the opioid can actually outlive the action of Narcan or naloxone, which is anywhere from 30 to 90 minutes. So if the person took a very long-acting opioid, it's possible that that opioid will hang around longer than 30 to 90 minutes. And then that person will again experience respiratory depression. And so that's why you want to monitor them very carefully. Next slide. And Charisse is going to share a video with you. This is from our website, morenarcanplease.com. I hope you'll all become very familiar with this website. Through this website and the funding we've received, we are able to provide free nasal Narcan to any Texan who wants it. So following today's training, you can go to the website and order your Narcan. We will send it directly to you. If you happen to be an organization, you can email us and we can have it shipped directly to you. I'm ready.
This information is brought to you by Team Cleveland at UT Health San Antonio School of Nursing. We're able to provide this training and free Narcan to all Texas residents through funding support we received from the Texas Health and Human Services Commission. So if you know someone using either prescription or illicit opiates who may be at risk for overdose, you really need Narcan, and you can order it here for free in Texas. Here's everything you need to know to jump into action. You suspect that someone has overdosed. First, try to get the person's attention by firmly rubbing your knuckles up and down the center of their chest. Next, call 911 and give them your location and the person's symptoms. Then it's time to administer Narcan, a nasal form of naloxone. You're about to save a life. Peel open the package to remove the Narcan device. You seriously can't mess this up. Just pretend it's allergy nose spray. Now, place the nozzle tip into the person's nostril until your fingers touch the bottom of their nose. Then, press the plunger firmly to release the dose. You just completed the most important step. Okay, now, check to make sure you're still breathing. Next, place the person on their back and tilt up their chin to clear their airway and help them breathe. Give a second dose of Narcan in their other nostril if the first dose doesn't wake them up within 2 to 3 minutes. Make sure you provide care for the person by rolling them on their side after you've administered Narcan until EMS arrives. Maybe pat their back so they know you're still there. Remember, they may be really scared and not feel well when they wake up. Make sure you stay with them until medical help arrives. You never know, this life-saving experience may just be the nudge this person needs to get into treatment and recovery. People recover from addiction every day. It's not easy, but it can be done. But you have to be alive for treatment to work. Look at you! You just may be the first step in this person's recovery journey. Yay you! Great job! And always remember, just keep breathing. We'd love to hear about the life you saved at www.morenarcanplease.com. You can report it here confidentially, and at the same time, order your replacement dose of Narcan so you can save more lives.
Now I'll turn the stage back over to Dr. Hill, who will talk to you about how exactly naloxone works and why we're able to do this in Texas.
All right, thank you, Dr. Cleveland. So I'm gonna keep this at a level that I think is accessible for everyone as we look at the next slide and a depiction of how naloxone is working when it reverses an opioid overdose. So if you were to take a large dose of any opioid agonist meaning an activator of the opioid receptors, we'll say those are depicted by those blue circles. It could be heroin, it could be oxycodone. If that dose is taken and it's at a low dose, it's going to lead to some pain relief. It's going to cause a mild sense of wellness, dulling sensations of pain. And when it attaches to receptors, opioid receptors in the gut, it's going to slow down gut motility. It's going to cause everything to stop and possibly lead to some mild constipation. As the concentration of that opioid agonist in your body increases and the saturation of those receptors, the proportion of those receptors that are activated at any one moment by those opioid molecules, it's going to start to have more severe effects. And at first that feels just even more euphoric. But at a certain point, when you get a high concentration of an opioid agonist at these opioid receptors, the green kind of lightning bolt looking shapes on the figure, when you get a large proportion of those receptors that are located on the brainstem agonized by an opioid, your intrinsic drive to breathe shuts down. And eventually your breathing can slow or completely stop to the point that you're not oxygenating other organs sufficiently for them to continue functioning. So breathing stops first, and then your heart stops later. If we can intervene before a person's heart has stopped, and we can administer naloxone, the green bubbly circles on this figure, it'll take about 2 or 3 minutes for the naloxone to find its way to those receptors on the brainstem. That's if it's injected by intramuscular or administered by an intranasal route, which are the 2 formulations that are appropriate for a layperson response to an opioid overdose. It's going to take about 2 to 3 minutes for that naloxone to find its way to those receptors. Naloxone has a higher binding affinity than most opioids, so it is going to essentially displace those opioids and attach to those receptors more strongly and more frequently to prevent the opioids from exerting that effect. Naloxone is what we call an antagonist or a opioid receptor blocker. It is not going to exert an opposite effect. It does not cause pain. It does not cause tachypnea or dramatically increased respiration, or at least it shouldn't unless you have underlying dependence and it's inducing withdrawal. So Claire mentioned earlier that you don't have to have an opioid use disorder in order to experience an overdose, and she was absolutely correct. And she followed up by primarily focusing on the fact that a person who uses opioids chronically for pain can also experience an overdose or opioid-related harm. I would add, and I want to make this a point to you all clearly, that a person who uses opioids occasionally, recreationally, not in a manner that would be considered disordered according to the DSM-5 and would not qualify as a substance use disorder, is also at risk for an acute overdose, given the increasing potency of the illegal opioid supply, the fact that there have been several incidents where a pressed pill that was being sold as hydrocodone or oxycodone was in fact all fentanyl. This has even happened with non-opioids. We have various reports throughout the country of amphetamines and cocaine and even benzodiazepine pills being sold as Xanax that have actually been adulterated with illicitly manufactured fentanyls. Now, it's really hard. We don't have great data here. And as harm reductionists, we want to be thoughtful and measured and avoid panics. But there is plenty of reason to believe that even if you don't use opioids, but you occasionally use cocaine or amphetamines, that you should have naloxone just in case. And certainly a person who even occasionally engages in recreational opioid use should have naloxone. So that naloxone is going to reverse the respiratory depression of an opioid within 2 to 3 minutes. And it's going to maintain a concentration around those receptors that prevents the opioids from having an effect for at least an hour. Now, it depends on the formulation and the resulting blood or plasma concentration that's achieved and how long that's maintained, whether or not the naloxone is going to be effective for more than an hour. But an hour is kind of a good rule of thumb to use when educating patients. The higher dose the formulation, though, the longer it's likely to actually work in practice. And I'll discuss that a little bit more when we go into specific formulations. The primary concern as far as adverse effects with naloxone is withdrawal. And Dr. Cleveland described very well the true agony of opioid withdrawal. The fact that even though it's not like benzodiazepine withdrawal, where it's likely to lead to acute harm, it's prolonged. It is it's torturous, and it drives people to use drugs again. There's a reason that it takes so many attempts to be successful in entering recovery. Relapse is not a failure, it's a part of the process. And the big reason that people are driven to use again is that withdrawal and the associated cravings that are triggered. Okay, if we move on, I'm gonna give a little bit of perspective about how we're able to have naloxone distributed for free from More Narcan Please, how pharmacies are able to offer it without a prior prescription. So as we go to the next slide, you'll see that Texas is one of 50 states and the District of Columbia that have passed some form of a naloxone access law. And those laws tend to include 3 core components. So on the next slide, the first core component to be aware of is standing orders. And these essentially allow a pharmacist to prescribe naloxone at their discretion under the delegated authority of a physician or another prescriber. Advanced practice nurses and physician assistants can also sign naloxone standing orders for pharmacies. You've got major chains in Texas that all have naloxone standing orders, and in theory, you should be able to walk in, ask for naloxone, either for yourself or for a friend, and you should be able to walk out with it that day. But it's not free, like at morenarcanplease.com, though it can be charged to your insurance. So third-party prescribing increases availability. Let's say that I am worried about my sibling. I'm worried my little brother has been using oxycodone and he might overdose, and I want to have naloxone around just in case. I can go to a local pharmacy, I can request naloxone, and they can issue it to me, even though I'm not the person at risk, and they can charge it through my prescription insurance. And this is an area that there's still some confusion for individual pharmacists. So you might want to call ahead if you wanted to pursue that method, or if you were to direct a patient to do so, to make sure that they're prepared. Obviously, a person going to a pharmacy to get naloxone because they were concerned about their own risk for overdose would probably not openly state that they were using heroin to the pharmacist. And so this actually just makes things a lot simpler and more straightforward without needing to interrogate someone regarding their reason for use or obtaining naloxone. Third core component is liability protection. And this is the one that by far we get the most questions about. And that is that the naloxone access law protects any prescriber, pharmacist, or layperson who administers naloxone from any liability, anything that could occur if they were acting in good faith. And this is true whether you prescribe, dispense, or administer naloxone, or whether you don't. So let's say that you distribute naloxone to a person, but you're in a hurry, you forget to remind them of a specific step and how it's administered, and ultimately they fail to administer it correctly and the person dies. There is no risk to you of liability. You were doing what you thought was right. You were in good faith attempting to increase access to naloxone, and that alone is sufficient to protect you from any liability. Tammy Harris has asked, does third-party prescribing, does that require a prescription? technically under a standing order, a prescription is issued. So anytime that a person would go to a pharmacy, a prescription would be issued by the pharmacist under the name of the delegating physician. And this would be true regardless of whether it's for a person at risk themselves or for what we call a third party, someone who might observe an overdose. So a prescription is being issued in the name of the recipient in either case. Moving on to the next slide, there is one component of many naloxone access laws that is not a component in Texas. And it's not a component because when the naloxone access law that included this component was put on the governor's desk, he vetoed it. And that is legal protection for victims of overdose or others who use drugs who may have called 911. Many states do have these so-called overdose Good Samaritan clauses or laws, and that would mean that, say, my brother and I were using Oxy together, and he decided to take a little bit of Xanax as well. A few hours later, when I look over and he doesn't seem to be breathing, and I do the sternal rub and I'm shaking and shouting and yelling his name and trying to revive him, and it becomes apparent that he is experiencing opioid-induced respiratory depression. In a state that did have an overdose Good Samaritan law, I could call 911 and I could know that he and I should both, with some exceptions, be protected from prosecution. In Texas, there is no protection for either of us. And so unfortunately, though Dr. Cleveland stressed the importance of calling 911 during an overdose situation, it is quite likely that many people who experience overdoses will not call 911, that the person who observes it will not call 911, or that if they do, they will administer naloxone, call 911, and then run away, or run away before they call 911. There are a variety of reasons that this might be, the person might determine that's the right choice for them due to risk of incarceration or other pre-existing warrants. So it's something we need to recognize. And as long as this is the case in Texas, we need to be transparent with people that we educate, with the public, that this is the situation. Now, certainly you're not at risk for prosecution if you're a person who uses prescription opioids for pain, if you are an innocent bystander who is not using any drugs. But if you're using illegal drugs, if you have paraphernalia, you are at risk for incarceration, for arrest, for criminal charges when you call 911. One of the really brilliant recommendations that Claire, who's a community harm reduction paramedic, gave to a group when I was watching once was that if a person calls 911 and they say their friend is having an asthma attack, it will result in the same level of priority when EMS responds as it would if it were a drug overdose, but you are unlikely to have police respond to the scene as well. So that is one strategy that we have educated folks about on a few occasions. Okay, so now we're going to move on to a quick review of each of the naloxone formulations in turn. So on this next slide, we're going to start with the oldest, the tried and true, the vial and intramuscular syringe. So next slide, you can see 2 vials of naloxone, 0.4 milligrams per milliliter. Oh, Sharice, if I could have you click to the next slide, please. So this is going to be the lowest cost formulation of naloxone. This is the version that community harm reduction groups, needle exchange programs have been distributing for decades with tremendous results. No form of naloxone has saved more lives than naloxone in a vial drawn up and injected with an intramuscular syringe. However, it has some drawbacks. It achieves the lowest blood concentration of any available form of naloxone for layperson use. It requires the most training. And I can tell you, if I were to think about a non-medical family member like my mom, trying to draw up that small 1 ml of fluid out of a vial that could probably hold 10 mLs, and her concern about whether, you know, a lot of people don't have great insight about these things. If there's a little bit of air in there, could it kill my son? I think there are real concerns about administration of this form. And it's important to remember that even though your patient is needle savvy, that does not mean that the person responding to their overdose is. The person who overdoses cannot give themselves naloxone. If they can, they're not overdosing. They do not need naloxone. Moving on to the next slide, we've got the version that you saw in some of the opioid response slides that Dr. Cleveland shared. And this was really developed for layperson use out of recognition that the vial and syringe could be difficult to use. This is called a prefilled syringe plus a mucosal atomization device, MAD, or just a nasal adapter for short. It's a little more pricey than the vial and syringe. So whereas 2 vials might run you about $20, two boxes of these prefilled naloxone syringes are probably going to be more like 40. And the price is changing as availability changes. This is going to achieve higher blood levels, higher plasma concentrations for kind of our more savvy learners. And so may be effective for longer. It does require some training. There are multiple caps and things to click off and put together. And notably, using some trainers, I have seen people break the glass portion that contains the medication. Because it was not created for intranasal administration, it's relatively high volume for something that you squirt in the nose. It's 2 mLs per dose. So it's recommended that you use the adapter, you squirt half in one nose and half in the other. However, I have seen it be effective even without that device and all squirted in one nostril. The concern though is with the large volume, it'll drain before it's fully absorbed. Before I forget about it, this brings up another point, which is that you do not need to be breathing in order to absorb naloxone. It is absorbed through the nasal mucosa, so it does not require active respiration. Okay, moving on to our third of 4 naloxone formulations for layperson use. This begins the branded and more recently developed formulations. So these are going to be higher in cost, but easier to use. And I haven't accepted money from any of these companies, I promise. But I certainly think based on some of the choices they've made programmatically, as well as us, that Dr. Cleveland and I would agree Narcan nasal spray is generally our preferred option when it can be afforded. At a cash price of about $150 for a box of 2, that can be a fair cost, but it's often covered by insurance. It achieves very high blood concentrations, which does increase risk for withdrawal, but also increases the duration of action, which might be preferable if you've got patients who are unlikely to call 911. And it really requires no training. If you pop open the front cover of the box after you order it and receive it from morenarcanplease.com, you'll see directions right there. You're completing this training, obviously, but you could distribute some of those boxes to friends or family members. That's perfectly legal in Texas without any extra standing order. Distribute it to whoever you want after you get it from morenarcanplease.com. And you can give them a quick training using the open front flap of the box. Okay, going on to our 4th and final formulation here, we've got the Evzio auto injector. And if you're familiar with the AviQ epinephrine auto injector, this is exactly the same device, it just has naloxone in it. It has a comically high price tag, over $4,000 for a box of 2. Nobody actually pays that, and there's a really good 60 minutes or 20/20 expose showing that the company did it all for some sort of tax rebate. Certainly that has colored my view of the formulations a bit, but ultimately it speaks to you when you open it up. It walks you through exactly what to do as you're responding, and it achieves very high blood levels. My concern about this auto injector in Texas, again, is that the person who you're distributing it to may not be the person who is administering it, and this only speaks in English. So it is not going to be helpful as far as the directions it speaks for anyone who does not speak English. Okay, I am going to flip it over. We're going to go through some frequently asked questions, and Claire is going to talk to us about passive fentanyl exposure. I am looking forward to this.
All right, thank you so much. All right, so we've gotten some really great questions in the chat. I just wanted to mention one because I think it's really relevant. So Destiny Yes. So this was your question. She wanted to know if you give naloxone to someone who looks like they may be having an opioid overdose, but they aren't actually, and something else is going on, can naloxone harm them? I want to be really clear that it won't. That's one of the things that's so fantastic about naloxone, why it's my favorite drug, is that if you give it to someone who is not experiencing an opioid overdose, if that's not the issue, it doesn't have anything to do. So it doesn't cause any problems. It gets metabolized by your liver, and then that's it. I could give myself naloxone right now and I wouldn't feel anything. It would just do nothing. So it's a really powerful medication. I'm a paramedic, like Dr. Hill mentioned earlier, and in the emergency departments, if someone's not really wanting to respond and we're not sure what's going on, sometimes we'll give them some naloxone just to make sure that we're not missing something obvious like that, and see if that gets them to wake up. So it's a very safe medication. You don't have to worry that you're going to inadvertently hurt someone. If you have any doubts, we encourage you to just give them naloxone. And that's another reason why it's good to call for help. If someone is not experiencing an opioid overdose, but they're not breathing well, they're unresponsive, then something else is very wrong. We definitely want 911, we want EMS to come help us. So that's a fantastic question. Thank you so much. So, all right, let's dig in. Next slide, please. Let's have a look at some of these questions. So yes, passive fentanyl exposure harmful. So what is passive fentanyl exposure? So I see these news stories all the time. But honestly, that's probably because I go looking for them. But some of you may have heard at some point a story, and it's usually involving police officers, that maybe they arrested someone on suspicion of having heroin or fentanyl, and some kind of powder was spotted and maybe someone touched it. And then a couple of minutes later, the officer felt very sick, and maybe their palms were sweating and their heart was racing and they couldn't catch their breath. And they thought, oh my God, I'm overdosing on fentanyl. So their partner goes and grabs a dose of naloxone, gives it to them. Take a deep breath and we feel better. So this is a really common narrative. We've heard it several times at this point, and sometimes there's some variation. But that particular set of symptoms and that particular kind of timeline is really common. If any of you were kind of thinking about those symptoms, you might be thinking to yourself, they don't really align with what we talked about earlier with what an opioid overdose looks like. In fact, it's kind of the opposite, right? So we talk about things like slow breathing or no breathing. So if you're talking about some kind of situation where you're having a really hard time catching your breath because it's really going quickly and you got sweaty palms and a pounding heart rate, this sounds an awful lot to me like anxiety, which is usually what's going on in this case. So we hear about this a lot, and normally it really wouldn't matter. Anxiety is not a fake thing. And being anxious and kind of hesitant because you're having to interact with some unknown substance is very understandable. So I think it's important to point out that none of this is an unreasonable response. It's just almost certainly not an opioid overdose. And this is important because if we get people to believe that fentanyl is capable of, dropping someone down like that with really passive, inadvertent exposure, then that's also sending the message that it's not safe to approach someone who might be experiencing an opioid overdose, and it's certainly not safe to touch them, give them Narcan, things like that. And this is not true. So there are patches, skin patches of fentanyl, and some of you may be aware of this, that are commonly prescribed to people, especially with chronic pain or really acute pain, like cancer patients get them sometimes. So fentanyl can cross the skin. I'm not going to say that it can't, but those patches are a really, really high dose of fentanyl, and they take hours and hours of sitting flush against your skin for the level of fentanyl in your bloodstream to reach a point where you're feeling pain relief, much less overdose. So fentanyl does not cross the skin especially well, especially not when it's dry, which is what we usually hear about. We hear about powders. And it also is a pretty heavy molecule. It doesn't like to float in the air. So that's another thing that I hear a lot is that, you know, well, what if it kind of gets tossed up into the air or it gets aerosolized and I'm breathing it in? And the nature of fentanyl says that that's really not how it behaves. There's kind of this running gag that we say that for this to work, we'd have to have a like Scarface-sized mound of fentanyl with a big fan behind it, blowing it into someone's face. So a really extreme, really improbable scenario. So I like to mention this because I see this a lot in local news, and I want to make it clear that that's really not what's going on. You cannot overdose on any of these drugs by laying hands on someone or giving them Narcan. If you overdose on fentanyl, it's because it was put in you on purpose. All right, next slide, please. Yep. So I mentioned first responders on purpose, not to pick on us, but that's usually who's the first person to interact with some kind of unidentified substance, because we're the ones going out into the field and going into people's homes and cars and things like that. So we usually hear about this kind of stuff from first responders. So it's important to remember those things. Fentanyl does not want to cross the skin quickly, and it doesn't like to float in the air either. It's really next to impossible to accidentally inhale it or accidentally get it into your skin without someone doing that on purpose. Another thing that's important is that fentanyl and all of its known analogs are not resistant to naloxone. I see that a lot too. Naloxone resistant fentanyl, naloxone resistant arylfentanyl or carfentanyl, things like that. All of those drugs respond to naloxone, all of them. I'm not aware of an opioid that doesn't. And sometimes they might take a higher dose. That's certainly possible, but that doesn't mean that they're resistant. And the dose in the nasal spray in Narcan is really high. So that's a dose of 4 milligrams. Generally in the hospital, we would do 0.4 milligrams or even less and maybe titrate up to that. And that still works well. So I really want to drive it home that it's completely understandable that this is scary. And there's nothing unreasonable about that, but the facts bear out that you cannot accidentally overdose on fentanyl. And even if you do overdose on fentanyl or someone around you does, naloxone will work. All right, next slide. All right, I'm going to hand this over to Dr. Cleveland, I believe.
So our next question is, where can I obtain naloxone? I am so glad I asked that question. Next slide. So hopefully by now you can answer this without any trouble at all. Of course, you can go to morenarcanplease.com where you can order a unit or a box of Narcan, which contains 2 doses. We are able to secure this at a reduced rate of $75 per unit. It's free to you. If you're a Texan, you just let us know you need it and we will ship it to you. Just one thing real quickly I did want to mention, and I'm so glad Dr. Hill mentioned that an individual does not have to be breathing for nasal naloxone to work. One other caveat too is we do want to be careful about temperature. So if you're carrying this in your car, that's probably not the best idea. Usually we say anywhere from 40 to 80 degrees. So ideally don't keep it in your car. However, if you do and you come upon an overdose, please use it anyway. The manufacturer tells us that it won't lose its potency, but it can evaporate. So it might be possible that you would need to use both doses in that case, but do use it anyway. Try to protect it from the heat and from the cold. You can also get naloxone from many of your local harm reduction coalitions, like this one in particular, the Texas Harm Reduction Alliance, which is in Austin. They do distribute naloxone. We also have a Bexar County Harm Reduction Coalition. that provides not only naloxone, but also syringe services programs. Bexar County, interestingly, is the only county where syringe services are legal, even though we know it's going on throughout the state. We hope that's something that will have some legislative attention in this next legislative session. Many chain and independent pharmacies, I know Dr. Hill mentioned this, are prepared to dispense the naloxone under the standing order. However, be aware that there may be a copay. And next slide, and over to you, Lucas.
All right, so the question is whether you can administer expired naloxone. And if we click to the next slide, this may be the only time in your entire life that a pharmacist tells you, yes, it is perfectly fine to use this medication after it has expired. With the exception of tetracyclines, there's no drug that's going to degrade into a harmful product, and naloxone is not an exception to that. So over time, naloxone will become less potent. And as Dr. Cleveland mentioned, if you put it in extreme temperatures, if it is exposed to light at the same time, there are certainly situations in which you can cause that degradation to speed up. But if you were to put a box of Narcan nasal spray in the hallway closet in your home and you pulled it out 12 years later, I can say with a high level of confidence that it would be completely effective against an opioid-related overdose. The high doses that are available in the naloxone nasal spray, the Evzio auto injector, are going to still be of a similar potency to the other versions that we know work, the lower dose prefilled syringe and vial, 10 years beyond their expiration date. Now that said, it is prudent, especially if you are an organization, that you replace naloxone when it expires to be on the safe side, to even though liability risk appears to be low for using expired naloxone if it's what you have. But when you get rid of expired naloxone, don't throw it in the trash. That stuff still works. That's a life-saving dose of medication that you could give to a client who might need it, a friend or family member who might need it, or if you've got a large number of doses that you could give to a harm reduction coalition that will gladly distribute it. So please do not get rid of expiring naloxone, and know that if it's all you can afford to keep around, you can keep the same old box for a really long time, and know that it won't cause harm and it'll still be effective. Okay, I think Claire's going to round us out here before Q&A.
All right, thank you. So I'm going to talk about a couple of practicalities and translating this into the real world. Many of you have had really fantastic questions along that line. So next slide, please. So Operation Naloxone is a program that's directed by Dr. Hill. We run at the University of Texas at Austin. We do naloxone distribution and training on campus, and also do community outreach. Like very recently, we worked with the Travis County Sheriff's Office to support their implementation of take-home naloxone for people being released from jail. So we support community initiatives, we do on-campus training, education, and naloxone distribution, and we also do continuing education. So both Dr. Hill and I have made programs, and we also bring in experts from other institutions in other parts of the country to help contribute and really round out fantastic CE. It's all free because it's all grant supported. So we are at operationnaloxone.org, and these are our social media handles. We always announce if we have something new or if we have some new information to share. So please feel free to follow us. We have continuing education for healthcare professionals as well as for lay people. So it's not skewed either direction. There's something good out there for everyone. Next slide, please.
And I also want to point out, I know we've mentioned this many times, but our website, morenarcanplease.com, where you can order Narcan for free. We also have a lot of resources posted here that are completely free for you to use. There's a 20-minute version of a training that a lot of community members use. It teaches about harm reduction, very similar to the program we did today. There's also a longer training of trainers that we recently recorded a couple months ago that can be used. I also encourage you to use the little 3-minute sticker quick figure video, particularly if you're educating a layperson who really needs Narcan and you just need to pull it up on your phone real quickly, show them how to use Narcan. That is available in Spanish as well. Some of our other trainings we are in the process of getting translated into Spanish, so I encourage you to access those. You can also engage with us through our media platforms, through Instagram, Twitter, and Facebook. You can post questions on More Narcan, please, and we will respond. Next slide.
And I believe we talked about X waivers earlier in the presentation. If we haven't, I missed that. Always possible.
So I'll put in a little plug for this because this is being run by my very dear friend and colleague, Dr. Jennifer Potter at our School of Medicine. And so we've talked a lot today about overdose prevention, overdose reversals, but that is not treatment. And people who are struggling with an opioid use disorder, they need access to treatment. And unless we have prescribers who can prescribe the only FDA-approved treatment for opioid use disorder, and that is medication-assisted treatment, we're not going to be able to get people access to the treatment they need. And so this program allows for an 8-hour standardized training. So for physicians, nurse practitioners, PAs, prescribers, they can do this waiver training and be able to prescribe buprenorphine, you may know of that as Suboxone, from an office. We also are doing some buprenorphine inductions in the community through our partnership with the San Antonio Fire Department, but I encourage you, this is a free training, and it's just a huge resource for our state. Next. So now we go into our questions and answers. And so as I mentioned, we really appreciate the thought that you put into some of the scenarios you posted for us and some of the questions. We tried to kind of group them together to hit as many as we can, but if we really miss something, please reach out to us through social media or through our websites and we'll try to get those questions answered. And so I think I'm going first. And I was really excited because we had several questions about pregnant women and new mothers. And this is really a passion of mine. And so I was really thrilled that Claire and Lucas let me take this on. And so one thing to really point out is, so we are in an opioid crisis in this country that does not necessarily equate to an opioid crisis within pregnant and parenting women, although sometimes you see the media really sensationalizing that. It just so happens that this crisis is also impacting that population. So I just want you to keep that in mind, to sort of keep this in context. And so with other individuals who have opioid use disorder, the standard of care is medication-assisted treatment, and that includes for pregnant women. There are decades and decades of evidence showing that women who are stabilized on methadone have better pregnancy outcomes. They tend to have better prenatal care, better nutrition, better birth outcomes, babies who weigh more, less premature births. And so we have lots of evidence for that. The evidence on buprenorphine is emerging and is really, really promising. And so right now, the recommendation is for stabilization on either of those medications. One thing to keep in mind, however, is these are long-acting opioids. And when a fetus is exposed to opioids in utero, that infant can then experience withdrawal following delivery. Okay, but one thing to keep in mind is that is a very predictable condition, and it's also very manageable. It's something we oftentimes refer to as neonatal abstinence syndrome, or now more specifically being called newborn opioid withdrawal. It doesn't last forever. It can be managed with medications. And so these babies are not born addicted. Something else you will see in the media, they don't need to go to rehab. If we think about addiction, what's really happening with these babies is they're just born experiencing physical symptoms of withdrawal, and we can manage those. Best treatment for a baby withdrawing from opioids is mom. And so we typically manage these babies with first line is non-pharmacologic soothing techniques. So these are techniques that work with any fussy baby. Holding, rocking, skin-to-skin holding, and yes, breastfeeding. Breastfeeding has been shown to help with withdrawal symptoms, and women who are stable on methadone or buprenorphine can breastfeed. The evidence shows that a very, very small, clinically insignificant amount even passes into the breast milk, and just the close physical contact of breastfeeding is really, really beneficial for these babies. The next question we received, and I wish I could ask questions because I'm not sure I fully understand. There was a question about, as nurses, some nurses interact with patients who they know have a substance use disorder, who seem to be seeking more pain medication than what really should be managing their pain. So I think there's a couple caveats to this question. If this is somebody who's been using opioids for a long period of time, as Dr. Hill so nicely explained, they have developed tolerance. And so you may be giving them pain medication, but all you're really doing is helping with their withdrawal symptoms. You're not getting at their pain. Also, if you have somebody who is on medication-assisted treatment with methadone or buprenorphine, that's not going to manage their pain. They're going to need a certain dosage just to manage their withdrawal symptoms before you start to address the pain. So I think this really should involve a conversation between a nurse and the patient about what's really going on with the patient and a little bit more about the history. And then my final one, oh, this is a really good one. So I get asked this question all the time. You know, we mentioned the whole thing about medication-assisted treatment. Isn't that replacing one drug with another? And at what point should you get off of it? That is such an individualized question. And I hope after our conversation about addiction as a chronic disease, that you can think a little bit differently about that. So we don't say this to somebody who has asthma. When are they going to be able to quit using their inhalers? We don't say this about somebody who's managing their blood pressure using medications, or somebody who suffers from chronic depression who uses antidepressants. Really, the key component is recovery is defined a lot of different ways, and not everybody defines it the same way. For many people, recovery means I can go to work, I can support my family, I can keep a roof over my head, I can parent my own children. And if taking a medication allows me to do that, then in my eyes, that's recovery. And I think I'll turn it over to, I think Dr. Hill is next. And please feel free to add to anything that I said.
Dr. Cleveland, I just wanted to mention one thing. There's a Q&A that's going to be relevant to you. So Destiny Sanchez says, so I'm assuming benefits of the use of methadone by pregnant women outweigh the risks. Would you agree with that?
Absolutely.
Thank you. Good question, Destiny.
Thank you for that.
Okay, so there were 3 statements or questions that I wanted to address specifically that were submitted in advance. So I'll read those one at a time, and then and one of them was also asked live. So that one is going to be, please address aggressive behavior from overdose victims after reversal with naloxone. And yeah, I'm going to do my best here, but let me also say that I'm adding a link right now to the chat from Ryan Marino, an expert toxicologist and emergency room physician that delved a little bit more deeply into this myth. So the reality is that there is no evidence to back up that overdose response or reversal with naloxone is a particularly high-risk situation for a first responder. There are a couple of case reports from, I think it says around 1990, that discussed this occurring, but more recent evidence shows that an emergency medical technician, a paramedic, is not more likely to experience harm at the hands of a resuscitated overdose victim than they are at the hands of any other person that they care for. It is not a high-risk situation, either due to passive fentanyl exposure or due to aggression. But because this is a highly marginalized and stigmatized population, they get that attached to them because of a few anecdotes. So notably, that's not something we need to be concerned about. I'll add to that, even though there are some delicate ethics in this scenario, many times emergency medical technicians, paramedics are going to titrate naloxone gradually. They're medical experts who can obtain intravenous access. So they're not going to administer a whopping dose from a Narcan nasal spray. They're going to get intravenous access. They're going to dose really lightly until they see a response, which you can get much faster with intravenous dosing. But they're going to just bring somebody back to the point where they're breathing enough to sustain life. They're not going to induce severe withdrawal and bring them out of it rapidly, generally speaking. Now, even when they do, I want to say that I think it's understandable that if a layperson were to reverse an overdose with a high dose and a person's going into withdrawal, that their response might not be what you expected it to be. So we do cautiously warn people that a person is probably not going to jump up and give you a hug. This is potentially one of the worst days of their life, especially because many times they're waking up surrounded by people they don't know in a place they don't remember going, and sometimes surrounded by people in uniforms who might try to lock them up or put them into involuntary treatment. So this is not a situation that they desire. This is not, people aren't regularly pushing the limits, hoping to almost overdose, because they know the experience of receiving naloxone, of being Narcaned, is not something that they want. So I bring that up because I'm glad it was brought up by an advanced question, because I think it's an important topic. The second question that I received was, how would you take care of a patient who has become dependent on a medication and needs that medication for their pain or other illness? Well, to be honest, I would keep going with the medication. If a person has severe type 2 diabetes and they need insulin to sustain life, sometimes you'll see something, a diagnosis in their record that says insulin dependent diabetes. Just because a patient needs insulin to sustain their life doesn't mean that they have an insulin use disorder. And the same is true for a person who requires opioids to function in their daily life. Now, it is certainly true that we have more people on chronic opioid therapy and more people on high dose chronic opioid therapy than is probably indicated. There are people who, by non-judicious or unscrupulous prescribers, were titrated to incredibly high doses of opioids and have severe physical dependence and may not even have had their quality of life or function substantially improved by the opioid. But that doesn't change the fact that decreasing the dose, especially if it's done dramatically or non-consensually, is going to result in better outcomes. So you'll probably be familiar with the CDC opioid guideline for opioids for chronic pain. I hope that you are also familiar with the clarification written by the same three authors last year. And it pointed out that there has been widespread misapplication of the CDC opioid guideline. They point to institutional and state level policies that push prescribers to decrease patients' doses of opioids. I don't have the exact language in front of me today, but those three authors of the CDC opioid guideline point out that while the guideline does recommend being cautious and avoiding titrating doses to more than 90 milligram morphine equivalents per day, it does not say anything about decreasing the dose for people who are already maintained on more than 90 milligram morphine equivalents. So that is just one example of ways in which laws and institutional pressures, dashboards that show who the high dose opioid prescriber is in the clinical group and pressure on them to decrease their prescribing lead to harm to patients. We have multiple studies now showing that when opioids are tapered, they tend to be tapered non-consensually. They're tapered aggressively over the course of 1 to 2 days, when really they should always be tapered no faster than over the course of a month. And that people who have their opioid dose tapered or discontinued are actually at higher risk for overdose death and higher risk for suicide. We need to be thoughtful and evidence-based in our approaches. My favorite speaker, Stephan Cortez from Alabama, internal medicine and addiction physician, he'll have a program available at operationnaloxone.org soon. His phrase about this is that we got our fingerprints off the bodies. And that's exactly what it is. It is not caring at the end of the day about what happens to the patient, but caring only about your own medical license. Now, there's plenty of reason to be concerned and to push back on medical board and other groups that might be imposing restrictions or pressures. But at the end of the day, you have a responsibility to the patient who's in front of you, regardless of what your profession is. And to push people dramatically or quickly off of chronic opioid therapy is not evidence-based. Okay, third statement is I have seen patients get multiple prescriptions for opioids from multiple physicians, and this leads to difficult encounters in the pharmacy. So this is a great point, a very difficult conversation and situation to be in. And now that advanced review of the prescription monitoring program before prescribing or dispensing certain controlled substances is legislatively mandated and will be enforced by medical and pharmacy boards, this is salient. We are going to have a lot more uncomfortable conversations with patients who we suspect of patterns of misuse of substances. I think that the current reality is that when a patient is identified, I can speak at least for pharmacy, and I think probably true in other settings. If a patient's identified as having a problematic PMP record in the pharmacy, they are likely to have their prescription rejected. They are likely to be told it's out of stock or some other lie to get them out of the pharmacy. They may face a threat that the pharmacist is going to call their prescriber. In a primary care office, they're probably likely to be cut off of their chronic opioid therapy that day. They may be kicked out of the practice. So the reality is that current responses to that data are also not evidence-based. None of those things help that person or protect their safety when they leave your office. That doesn't mean that you have a duty to continue prescribing or dispensing opioids to a person who you believe is misusing them. That is an incredibly difficult situation legally and ethically. But at a minimum, you have a responsibility to that person to offer naloxone, to educate about medications for opioid use disorder treatment, to refer them to the local harm reduction coalition and provide information about sterile injection education and accessing sterile syringes. You need to prepare for engaging productively with people who may not have your same view of what is right for them. It is not always going to be the case that your patient is going to agree that abstinence is the right final goal. For some of our patients, continued use that is safer is the final goal. That is as far as they want to go, and that is fine. That is so much better than where they are at today, and that you're going to meet them where they're at, just like Claire says. Okay, I'm going to end it there and hand it over to Claire to respond to a few questions.
Thank you, Dr. Hill. All right, so I too have some questions that we pulled from the pre-submitted questions from the audience. So some really fantastic ones. I just want to thank everyone in general for submitting them. I found them really illuminating and also very moving. So I really appreciate your candor and for participating to this extent in our webinar today. So my first one says, I have clients at times that stopped using, but they have not really changed their other behaviors. Dry alcoholics, abstinent addicts that are challenging. The clients talk the talk, but they do not walk the walk. So I think this is a useful question for a couple of different reasons, because it gets into two different big things for me. And one is something that people have been talking about in the chat the past couple of minutes, and that's the issue of stigma. So terms like addict or junkie or druggie are really, for me, never words. And I really hope that they are for you as well, and you try to get there. Stigma is not just unkind. I mean, it certainly is, and it's certainly othering and alienating, but it's also backed by the literature to worsen outcomes. So even if you want to approach this from a hyper-rational kind of standpoint, then know that by endorsing or allowing stigma within your patient care setting that you are also endorsing and allowing worsened outcomes when you really don't have to. So people who use drugs who experience stigma, especially in a clinical context, are shown to be less likely to enter treatment and more likely to relapse if they do complete treatment. They're also less likely to find social connection to social support. So there have been a few different studies that have looked at this, and there are several different layers of stigma, and I could talk all day about stigma. It's a complex issue, of course, but I certainly won't. A big thing that you can do right away is you can eliminate words from your language or from your, lexicon that reinforce harmful stigma and reinforce this kind of othering behavior. A big one for me is addict. So someone can be diagnosed with an opiate use disorder or a substance use disorder or alcohol use disorder, but we really want people to get away from addict. Junkie is very hateful, so please never use that. I have heard many people tell me that even if their doctor or their nurse or their pharmacist is clearly kind of awkward or stilted and trying to tiptoe around language, the fact that they're going to that effort and they're feeling that experience of otherness and kind of newness and practicing really proactive language is very reassuring and welcoming to them, and makes the patient more likely to be open and honest and forthcoming about what's going on, so that we can all be on the same page and, you know, get to a good outcome efficiently. So that's my bit about stigma. Our colleague Rich Botner here at the University of Texas at Austin just very recently launched a AAMC funded website called resetstigma.org. So it offers free toolkits specifically geared towards people who are either in the clinical setting or in like treatment or recovery. There are kind of a couple of different options there. And it's really like clear, awesome, actionable tools to help get everyone in your facility on the same page about rejecting stigma and being more welcoming. So as a reminder, to recap, it's not just unkind, it is demonstrably bad practice. So we want to get rid of as much stigma as we can and be as loving and compassionate of our patients as we possibly can. Another thing about that is kind of, you know, let's go back to what exactly this question is saying. We're talking about dry alcoholics, abstinent addicts, talking the talk but not walking the walk. So I think an important thing that this brings up is the idea of what our goals should be. What are our realistic outcomes? So I went and I looked up these terms. They are 12-step origin, which is not something that we discussed here, but I imagine all of you are familiar with it to a certain extent or another, with maybe AA or NA. And there's a lot of back and forth about the validity of these programs, but some people definitely find success in that path, so I don't want to knock it. But I think this is a good example of what Dr. Hill was mentioning earlier, that we need outcomes and goals and treatment to be guided and dictated by the patient. What do we actually want? It needs to be something specific and definable. So if someone does have a diagnosis of an opioid use disorder, for example, and they are abstinent and that is their goal, then kind of what more do we want here? So those terms kind of refer to psychological behaviors and thought processes that are seen as being typical of addiction, even if the person is not engaging in substance use. Things like blaming, acting out, kind of fatalism and spiraling and things like that. Honestly, none of this is surprising. Negotiating substance use is a difficult task. I hope if you take one thing away from this, it's that this is not a straightforward road, and it's often difficult. So I think it's completely reasonable to expect patients who are going through this and trying to get to a point where they have success, whether that it's abstinence or just, you know, safer use, to have some bumps along the way. and they may not be super happy. It may be disorienting. It may cause anxiety. It may prompt, mood swings or lashing out. And if you think about it, I feel like all of these are pretty reasonable and to be expected. So that's what those terms refer to. If someone else wants to kind of pop in on that, I'd love to hear more about it. Again, you can always contact us over social media. I like to say that we are a public service, and we are here for y'all. So always feel free to get in touch with us if you want to discuss that more. Second one is very close to the first one. It says, I still see and hear a great deal of judgment, stigma, stereotyping, and overall negativity towards substance use and addiction. This is even in the Department of Psychiatry. So yeah, absolutely. I've seen a lot of it too. I continually see a lot of it. There's nothing about being educated and, in a clinical position, being a physician, being a nurse, that insulates you from this. It's from, probably your earliest memory. We've been raised in this context of thinking that drug use is a moral failing, that it's something that people are opting to do to either harm themselves or others. And it kind of gets us into this stew of wanting to blame people for their substance use. And it's far more complex than that. And that's definitely something that we are all taught in our culture. We're products of our culture. It's just how it is. So I understand that this is something that virtually everyone needs to actively choose to overcome. And that's hard work. And there is already a lot of hard work on everyone's plate in healthcare. I imagine I don't have to tell anyone that. So yeah, absolutely. This is something that I see all the time, and I imagine all of you have as well. The short answer that I have for you is that it takes work, and you have to be willing to invest the time. So I encourage you again to go check out Reset Stigma. That's a really handy prepackaged set of tools that you can kind of take and go and work on implementing right away. It doesn't require you to do like research or build something up or contact a consultant. It's ready to go. I would encourage you to do this the same way, if you're a nurse, you probably had to go through extra training to talk about, things like CLABSIs and line infections and preventing UTIs. Like, we're used to doing extra work and extra training to address problems that come up in the line of our work to enable the best possible patient outcomes. This is just another example of that. So, yeah, that's my short answer is that, we are raised, in Western culture to believe that drug use is a moralistic issue when it really is not. And you should not feel that there's anything wrong with you if that's your initial belief, because we're products of culture. But you do need to take the effort to realize that it's, maladaptive way of thinking, and that we need to push past it for the benefit of our patients and also for the benefit of you as a human. Okay, and the last one I have here, I think this is a great place for me to end, because it will allow me to end with an actionable point here. It says, how should I respond when a hospitalized patient becomes frustrated and ultimately returns to the streets to get opiates? This is a fantastic question. It is a big problem, and it's something that is being addressed head on here. So I get to brag on UT Austin and Rich Botner again. So our colleagues, Rich Botner, who's a physician assistant at Del Seton Medical Center and on the faculty at Del Medical School, as well as Chris Moriarty's, who's a physician at Del Seton Medical Center and at Del Med. So they created the B team, which stands for buprenorphine team. And what they do is they have created an interdisciplinary team. So there are physicians, PAs, students, chaplains, pharmacists, social workers. It is a fantastic motley crew, and they are all together with the goal of addressing this exact issue that you're talking about. So if you think back to what we talked about earlier in terms of craving and this intense drive to stop the horrible torture of withdrawal, it makes a lot of sense, honestly. Something may be going wrong. You may have a very good reason to be inpatient, but that experience is so intense, it's really difficult to counter. So I hope you have a lot of respect for your patients and what they're going through. So what the B team has done is, if there is a patient in that scenario, so say a patient who has an opioid use disorder and routinely uses opioids illicitly, and they're brought in inpatient for something else, the B team will actually go offer to induce them with buprenorphine while they're in the hospital. And this is pretty uncommon. The most common scenario for starting on buprenorphine or another medication for opioid use disorder is to go to an outpatient clinic. And in this context, they start it in the hospital. They start it while the patient is inpatient. And this is really, really powerful, because not only does it take the bite out of those cravings, it stops withdrawal so they're not miserable. So it helps the patient refocus on their recovery from whatever they've been admitted for. It frees up mental and emotional bandwidth. If you're so preoccupied with just eliminating the experience of withdrawal that it's all you can think about, then you're not going to be able to think about things like ambulating, toileting, just getting better from whatever you're in there for. You're just focused on that. And that means that it's more difficult to kind of get to that endpoint that we want. So starting these patients on buprenorphine in the hospital is really powerful in that regard. It also makes them healthier patients. This one of the things that we described earlier for the symptoms of withdrawal are things like vomiting and diarrhea and sweating. So these patients can sometimes dehydrate themselves or even veer into the realm of electrolytes derangement because they've spent so much time vomiting and having liquid stool. So they're more medically complex patients, and they're really miserable and uncomfortable, and it's hard to kind of work with them as part of a patient care team. So I'm a big fan of this model. Del Seaton is not the only place that does it, but it's still a pretty uncommon model. So we're trying to get it rolling out more and more. I will share a link to a blog post where they wrote about this model, as well as contact information if you're interested in kind of setting up a similar program at your facility. It does not require having an addiction medicine service pre-established. So this is not something that's only going to be, just for big academic medical centers. It's something that can be realistically and safely and effectively rolled out pretty much anywhere. But that's a very challenging issue. And if patients leave against medical advice because they're so direly needing to get out there and get, their cravings eliminated and withdrawal eliminated, generally if we have to readmit patients that left AMA, they're in worse shape than when we started. So there are multiple reasons when we think about patient outcomes for us to do things like this and to work proactively with them. So it's fantastic questions. That's the end of it for me. But it looks like we have some exciting stuff going on in chat. So is there anything that either of y'all want to talk about?
So there's I think we are getting ready to wrap up. The questions are slowing down, but there's been a couple of really interesting ones. So Claire, I'm so glad to hear you talk about the B team, because it's never made sense to me why somebody comes into an ED, we treat their abscess, but we don't even offer treatment for the underlying problem, and that is substance use disorder. So I love that model. So a question did come in while you were talking, and it was asking about non-pharmacologic intervention for newborns experiencing withdrawal. And I'm not a very fast typer, so I was typing as fast as I can, but I'd like to expand just a little bit. So there's no confusion. Really, typically with newborns, we say their first line of management is comfort measures that we discussed. And if we're able to manage the baby through the withdrawal with comfort measures, then we don't have to progress to medications. If medications are required to stabilize a newborn, so it depends on where you are in the country. This might be morphine, it might be methadone. In some parts of the country, they're even using buprenorphine. So those can be effective, very effective in managing withdrawal. However, once medications are initiated, we know from research that will significantly prolong the infant's length of hospital stay and separation from his or her family. And so if you've ever taken care of an ill newborn or an ill infant, oftentimes what they really want is to be held. They want to be comforted, and mom or whoever that primary caregiver is really good at that. And so that's why we start with non-pharmacologic intervention before going on to pharm intervention if we need to. So I just wanted to clarify that a little bit. There was also a question about why would a prescriber select one medication over another? And I don't know if either one of you wants to take a stab at that.
I would love to, if you don't mind. So I just sent a chat on the topic, but it's certainly a great and incredibly complicated question, and can be very dependent on an individual patient's needs. Even though, if you look in the chat, after I finally figured out how to send to all panelists and attendees, I started just crushing you guys with responses. But you see, I'm not a big fan of naltrexone, which is kind of like a long-acting naloxone. It's just a blockade, and it has some unique risks, and the evidence supporting its use is just not as strong. So methadone and buprenorphine ultimately are the two drugs that are proven to reduce mortality in patients with opioid use disorder, keep people alive longer. Generally speaking, there's a trend toward methadone likely being more effective, but it isn't generally a significant difference. It's in meta-analyses you can see a trend. And it makes sense because methadone's a full agonist. It's AKA a stronger opioid. So patients for whom bup does not quite take the edge off and ultimately prevent a recurrence of use of illegal opioids, methadone can be titrated to a higher dose and give that extra effect that's needed. However, in the US, methadone use is so heavily restricted, with in Texas needing to go to an opioid treatment program every morning to get your observed dose until you can gradually start to get a few take-home doses. You've got to show up at a very early hour, wait in line, disrupts your ability to take care of your family, to hold down a job. It's very problematic, though, the level of regulation that stands between a person and their methadone dose. So I would say, as a general rule, you can think of buprenorphine as probably the most common first line, and then methadone often as a second line agent for people for whom buprenorphine is not as effective as necessary. That's a very imperfect description. And there are some people who really want naltrexone, AKA Vivitrol, who must be on that because it's court ordered, because the place that they're going to live after they get out of treatment requires them to be on that, won't allow them to be on an active opioid agonist or partial agonist. So it can be the right option, but usually that's not for a clinical reason. And a quick loop back to a question about scam rehab programs, and just want to say, as I did in the chat, that the majority of addiction treatment centers would fall under that category, in my opinion. The unfortunate reality is multiple recent studies have shown that most inpatient rehabs do not offer any of the 3 FDA-approved medications for opioid use disorder, even Vivitrol, which essentially means in the era of ultra-potent illicit opioids, they are death traps for people with opioid use disorder. So if you need to get a friend or a family member or yourself into treatment, you should call in advance, confirm that they start methadone or buprenorphine to alleviate withdrawal, that they continue it through discharge, and that they connect you with outpatient treatment afterwards, because many will claim to offer medications. It will be only Vivitrol, or they will only give you a week or two of bup to taper you through withdrawal and then discharge you on nothing.
Thanks, Lucas. And thanks, Claire, for sharing the stigma reduction toolkit. I just wanted to circle back just real quickly, because we're almost out of time, about stigma. So a couple years ago, we began providing education about substance use disorder and the role of stigma in healthcare for our undergraduate nursing students. And they were incredibly open and receptive to it, which was so encouraging to us. But then something really crushing happened as they got out into the clinical care environment, and they observed the very stigma we had talked about, and talked about the really grave harm that stigma can cause. And so we felt like we kind of put these students in a situation where they just were really didn't have the tools they needed to address what was happening. And so several of my colleagues and I, we recently published a paper. It should be in print very, very soon. But we wrote a paper about stigma, particularly in the maternal child population. And then found an instrument that was developed by Lenora Marcellus, who is a nurse in Canada. Really great instrument, and it gives clinical providers the language to address stigma in the healthcare environment when they observe it without being confrontational. It's a really nice instrument. I wish that we did purchase open access, so I'd be happy to share the link with any of you once it's available. But I think I like it because it gives you an instrument. It gives you some tools that you can put in your toolkit that will help you address stigma when you observe it. So please stay in touch with me. Hopefully that link will be available soon. I'm happy to share it with you. I will try to remember to also post it on the More Narcan Please website. So stay tuned for that.
I'm glad you mentioned that. One of the questions in the chat had to do with like the role of nurses in pushing back against stigma. So I didn't know if you had a specific set of insight, but it sounds like there's a toolkit about to come out.
Oh yeah, Lenora, it's called the ACT script, and she provides scenarios, and then what would be some language you could use to draw attention to that, to maybe help that person self-reflect a little bit, and to recognize that language is harmful, and that it's harming patients. And so I would be happy to share that with you. I think it's going to be helpful.
That's fantastic. Yeah, I think there's a lot of, us in healthcare, I feel like there's a lot of exposure to stigma and a lot of reinforcement of it from preceptors, professors, kind of going on down. And it takes active work, I believe, to push back against it and to choose a different method of speaking to and about patients.
I would agree, absolutely. And I think over time, it becomes a part of the culture on certain units or certain clinics. It becomes this accepted part of the culture. But really, there's no excuse for bad behavior. That should just never have a place in our healthcare field. And so if we're not addressing it, we're becoming a part of the problem instead of a part of the solution. So let's not sit back and tolerate it. We really need to be addressing stigma every chance we get. All right, well, I think we're just about out of time. I think the questions have slowed. It seems that they have. I encourage you all to engage with us on social media. If you think of a question later, we're here for you. Happy to provide you with additional resources, hop on the phone with you if you have a concern. Please don't feel that you can't reach out to us. We are definitely here for you. Any closing statements from either you, Claire, or Lucas? Thank you so much. This has been a lot of fun. It's been great to do this cross-system collaboration. It's been a really great time.
I would just say thank you to you, Dr. Cleveland, for inviting us, for reaching across the aisle to another institution, and the amount of energy it takes to create an extra presentation webinar like this, get the president to speak. It's very cool, and we appreciate your dedication, and we appreciate everybody who joined tonight. It really means a lot to spend your Monday evening with us on International Overdose Awareness Day.
It really
Thanks,
does.
Dr. Hill.
I would only reemphasize that we are accessible to all of you, every single one of you. So don't think that you can't reach out if you have questions or would like a link or would like something to implement what we talked about today. Please let us know. We're here.
And I think, Sharice, did you have a closing statement?
Yeah, this is Sharice. I just wanted to let everybody know that tomorrow we will be sending out an email on the continuing education credit and also a certificate of attendance if you don't need CE. And I will make sure that you have access to this PowerPoint so you can keep for reference, and it has all the links and all the social media stuff. So that way you have it on hand so you can get your questions answered or share the information with other people.
Thanks, Sharice. And thanks everyone for engaging with us. This has been so much fun. Go out and make a difference. I know you're capable. Have a great evening. Bye, Claire. Bye, Lucas.
Bye, everybody.